Good afternoon and welcome to the latest YouTube Live hosted by the National Cancer Institute. My name is Fadich and I'm the Vice President at Men's Health Network, a national nonprofit educational health organization dedicated to improving the health and well-being of men and their families. You can find us at menshealthnetwork.org. I welcome you to what promises to be an interesting discussion about the present and future of diagnosing and treating prostate cancer, and perhaps many things that you did not know about prostate cancer. In addition to the topics that will be discussed in this broadcast, we have also provided links to videos that contain supplementary information about both clinical trials and how to contact NCI's Cancer Information Service. To access these, please click the letter I in the upper right-hand corner of the screen, and you'll see the videos. Moving on, I am pleased today to be joined by two experts in the field of prostate cancer research and treatment. First, we have Dr. William Dahut, the head of prostate cancer clinical research section, as well as the Center for Cancer Research clinical director at the National Cancer Institute, and also Dr. Heather Cheng, a physician and assistant professor in the Division of Medical Oncology at the University of Washington. Welcome, Dr. Dahut and Cheng. Thank you for joining us.
Anna, thank you very much. This is really a great opportunity to let folks know exactly what's going on in the world of prostate cancer, and particularly about some of the more recent findings about the importance of what we call germline mutations, or mutations actually that one is born with, and what impact that has actually on your risk of cancer, and also on how that may impact decisions you make along the spectrum when you have prostate cancer.
Dr. Cheng, would you like to say a few words?
Yeah, I think recently we've discovered something that we've, more information about what we've known for a long time, which is that men who have a family history of prostate cancer are at higher risk of prostate cancer. And that's something that's been recognized for a long time. But we've been able to extend that further by recent findings looking at men with more advanced prostate cancers, those who develop metastatic disease. And what we've learned is that those men actually have a higher, many of them have inherited or germline mutations that overlap with cancer risks for other syndromes or other types of cancer. So in other words, having a family history of breast cancer may actually increase your risk of prostate cancer because the genes are related. And so a really well-recognized set of genes are BRCA1 and 2, which are best known for their association with breast cancer risk. And many of you may have heard about Angelina Jolie and her kind of efforts at trying to prevent prostate cancer, or I'm sorry, breast cancer development. And so that is now feeding into our knowledge about prostate cancer. And so we know that those same genes confer an increased risk of prostate cancer. And it's exciting also because there are new treatment opportunities for men who have prostate cancer with those genes. But it also means that family members or male relatives, nephews, sons, and so forth, might also be thinking about how they could screen for prostate cancer and detect prostate cancer earlier. And that might help us make a difference in how we catch the disease, when we catch it, and what we can do to intervene and make a difference.
Great. Well, thank you both for joining us. So these days you hear a lot about surveillance when it comes to prostate cancer. Dr. Dahut, what can you tell me about the role of surveillance in prostate cancer?
So I think prostate cancer is a very different cancer in a lot of ways than many of the other solid malignancies one has. So it's different, I think, than pancreatic cancer or lung cancers, because many men will have prostate cancer but not actually die from their disease. And the use of the blood test, the PSA test for prostate-specific antigen, led to a significant increase in detection of prostate cancer. But it's highly likely that we also detected prostate cancer in men whose cancer would never have had an impact on either their quality of life or on their overall survival. But the decision to not treat a prostate cancer immediately is a very difficult decision for patients on many levels. There's a very strong emotional component to the word cancer. And I think sometimes if we actually called our prostate cancer that was not as aggressive by a different term, that some of these decisions would be easier for men to make. Currently, the way we really recommend what we call surveillance is based on how much cancer one has in the initial biopsy and what we call the grade of the cancer. And the grade of the cancer is really a score that your pathologist gives to predict how likely the cancer is to escape from the prostate. Now, traditionally, prostate cancer biopsies were done what we call randomly. So urologists would biopsy certain areas of the prostate that could safely be done and that were areas that were likely to have prostate cancer involved in it. More recently, at many centers, including our own, we've included something called parametric MRI imaging, which allows the urologist to increase the ability to actually biopsy lesions where cancer may occur. And I think combining your biopsy material and what the pathologist is really the first step in deciding whether one should have surveillance. Now, I think surveillance is really important to realize it's a very dynamic term. So it's not like the old watchful waiting term one used years ago, which is simply an idea that your cancer was never to be treated no matter what. And anywhere along the line, there can be a change in the patient's prostate cancer risk that would really change one's opinion about whether or not one should actually go forward with more definitive treatment. So making the decision on surveillance often is a combination of the number of positive biopsies and, again, the grade of the tumor. But there are other variables which we look in order to help make this determination. Some are very personal decisions. For some men, the avoidance of any side effects at all from local treatment sort of trumps the potential ability for surgery or radiation, to delay metastasis or have an outcome on survival. But I have to admit there's a lot of gray area between deciding who should be a candidate for surveillance and who we should recommend for treatment. And I think some of this increasing new information about genomics and also defining what's meant by a family history in a way that's more than simply my brother or uncle had prostate cancer is very important. Because what happens in families is if one person in the family has prostate cancer, that often leads to the search for additional prostate cancer in other family members. And simply by additional biopsies in additional patients, because we know the incidence of prostate cancer is so high, one's likely to find more prostate cancer, and then thus one has a family history. And this is actually very different than having what we call a germline mutation, or really a finding in one's DNA that one's born with that gives one a propensity for cancer.
Okay, great. Dr. Cheng, do you have anything to add to that?
Yeah, I think those Dr. Dahut makes excellent points in terms of the family history and not all family histories being equal. I think one of the things that we begin to recognize is really just having a family history of prostate cancer is not enough. We should encourage our patients to ask about the details of that, and was it a low grade cancer, for example, a low Gleason score, was the PSA lower, was it higher, did that family member develop more aggressive disease? And those are pieces of information that are important for the many members of the family to know about to help inform their risk, because having a brother with Gleason 6 disease may be very, very different from having a brother who had metastatic disease. And we're still learning about how to better assess that, but certainly getting that information. And the same can be said for family history of other cancers, knowing who in the family had breast cancer and at what age, and how to the best of our ability to try to assess how aggressive that is, because cancers that are screened for can be detected at different stages and may reflect different biology, more aggressive or less aggressive, and that can also be in turn helpful in understanding a person's risk, knowing how aggressive their family members' cancers might have been.
Great. Dr. Cheng, what can you tell us about prostate cancer and germline mutation?
Yeah, so that's related to what we were just talking about, and germline mutations, and Dr. Dahut alluded to this before, are mutations or variants, let's say, genetic changes or genetic findings that we all carry, some of which are change the function of certain genes that do certain things, and others findings or other alterations are neutral. So some of that it's the blueprints of who we are. Some of the changes make us unique and may create an extra risk or additional risk for cancer, but other findings may be neutral. So certain, for example, nucleotides may be just part of the background and not harmful or helpful in function, and others may be disruptive of gene function, which can lead to an increased risk of cancer. So when we talk about germline mutations, it's really what you inherit mom and dad, and it's what you were born with. And every cell in your body starts with those blueprints. And over time and over a lifetime, things happen where mistakes are made, and that can lead to cancer. So when we talk about tumor-specific mutations, those are mutations that arise only in the cancer and are perhaps related to the development of cancer. But there are also certain people who inherit a risk of cancer because one of the copies of their genes, because we have 2 copies of every gene, may be slightly altered from the beginning. So it doesn't mean that people will definitely develop cancer, but it may mean that an individual who inherits that might be at higher risk. And that is what we're learning about more in prostate cancer in terms of certain mutations now conferring a higher risk. So we now know that there are some genes mutations that lead to an especially high risk, so that perhaps we should be paying more attention and thinking about that in screening for an early detection for cancer.
Okay. Anything you would like to add, Dr. Dahut?
No, I think it's important that traditionally we hadn't really thought of prostate cancer as a familial disease in the same way as we think of other cancers. And a lot of that is because it is such a common disease. Although the numbers are going down somewhat because there is less screening going down. Roughly between 160,000 and 200,000 patients are diagnosed a year with prostate cancer. So to actually look at the subset of men that would have a very high risk of prostate cancer because of a germline mutation, that's not always as easy to detect as in some cancers we see in pediatrics or in other more rare tumor types. But I think the population of men who do have these particular mutations are very important. And I think, as Heather mentioned, the fact that the family history may not be a prostate cancer family history, but maybe actually cancers often on their mother's side, whether it's ovarian cancer, breast cancer, or pancreatic cancer. There may be clues that this is simply more than a sort of a typical screen-detected prostate cancer. And I know Heather's spent some time actually looking at clinics to sort of look at families in some more details. And I don't know whether she'd be able to sort of describe some of the work she's doing out at Washington.
Yeah, so we thank you for that lead-in. We recently launched in response to these new developments and findings in prostate cancer and the importance of family history. We have now a prostate cancer genetics clinic at the University of Washington and Seattle Cancer Care Alliance, and it's really in response to these findings. And many families and many men are well aware of the prostate cancer family history or the breast cancer family history or ovarian cancer family history, and are wondering where to go. And so this is to help guide. The clinic is set up to help keep pace with the developments that we are learning about. So this is rapidly changing. We're still learning as we go. There's a lot of excitement and a lot of unanswered questions. And so I think for people who are interested in learning about these things, the updates or the developments are changing quickly. And for example, we know that I'm a medical oncologist, so we'll get to this a little later, but there are also important treatment implications for some of these mutations. But in thinking about prostate cancer risk for sons and nephews, for example, that's also an unanswered question in terms of thinking about early detection, thinking about active surveillance. So our clinic is really designed to incorporate considerations of prostate cancer treatment in with genetics, and we have a genetic counselor who's available to see patients at the same visit. And that's something that is relatively new, I think, to the field of prostate cancer, much more well established for colon cancer and breast cancer, for example, where the familial associations and the actions that we do in response to that are much more developed. So I think that hopefully it's going to really lead to improvements in how we care for men with prostate cancer and how we look for cancer in their family members. But that is the reason for the clinic. We also have a family study or family studies where we're looking at families where the genetic cause or the specific gene is not yet known. If we look back 20 years ago, we may have recognized at that point that certain families had a high incidence of breast cancer, for example, and we've now solved some of those families with breast and ovarian cancer risk genes, and now we know that those overlap with prostate cancer risk in some cases as well. So we're identifying new genes, some of which have been known to be associated with breast and ovarian cancer, but it's also the case that we probably haven't identified all of the genes that are known. And so for what we can do is we can test individuals who have a strong family history for known genes that are associated with cancer risk. And the panels now can encompass a number of different known risk genes, and we are adding the whole field more genes that we know to be associated with different cancer risks. So while in the past we've said, oh, there's breast cancer risk and ovarian cancer risk, now it looks like there's there are genes that now have newly been associated with newer types of cancers. So in other words, breast cancer is not limited to cancer risk for breast. It can also affect the men in the family for their prostate cancer, and may also confer risk for other cancers such as pancreatic cancer. And so I think we're learning with our new tools the importance of this. And so we are able to refer our patients also for pancreatic cancer studies where they are looking for early detection of pancreatic cancer, breast and ovarian cancer prevention. So we're really trying to help both the patients with prostate cancer, but also think ahead for their family members if they have any risk that we can potentially intervene on, or involve them in clinical trials where we can advance our ability to screen for other types of cancers. But we're also, the family study is looking at solving new genes as well. So we test for the genes that are known. We also look for families where we recognize that there is a familial association, but we don't yet know what the genetic cause is, and we can try to use family studies to try to learn about new genes and identify new genes that then will become part of standard testing.
So what can we learn about drugs and pathways from other diseases?
So I think a couple things. One, I thought the whole idea of finding one drug for one pathway is a very complicated topic. And what we have learned from other diseases is that sometimes drugs which we may be targeted against breast cancer or pancreatic cancer or lung cancer, if the same pathway is found in patients with prostate cancer, may work better than other drugs targeted against prostate cancer. Pathways, there's really two different things you need to think about. One is, the genetics of what the patient was born with, and then also the genetics of the tumor itself. And these can be different ways to go ahead and design treatments for patients. So if one's born with a germline mutation, and we'll have Heather's going to talk about that a little bit later, there are certain populations, or excuse me, certain groups of drugs in which we're seeing efficacy in prostate cancer that we hadn't really even thought about in years gone past. And also when we find a similar type mutation in the tumor, often we can come up with drugs that are targeted in a similar way. So these are are drugs which we talk about in the DNA damage pathway. And again, are definitely very promising early.
I might add also along to expand on what Dr. Dahut was saying, we recently did a study of men with metastatic disease and found when we sequenced their tumors that about 1 in 4, 1 in 5 have defects or mutations in DNA repair that he alluded to, half of which are inherited, were associated with an inherited mutation, and half of which just arose completely in the cancer itself and would not be passed on to children. Both of those groups, all men who have tumors that have defects in DNA repair, we think will benefit greatly from treatments that are used in other cancers. The DNA repair deficiency seems like it confers sensitivity to platinum chemotherapies, as well as a class of drugs called PARP inhibitors that are used for breast and ovarian cancer, particularly ones also with the same types of DNA repair mutations. And collectively, it looks like prostate cancer patients who have tumors that have these mutations have an exceptional response to these treatments that we haven't previously been using for prostate cancer. So the field is quite excited, and there are many clinical trials now open and coming, soon to come, that are involving looking at tumors to see if they have these mutations to try to get them treated with these more effective drugs. And there are also studies that are less prostate specific, such as the NCI MATCH trial, which are using a similar approach where we're sequencing tumors of different types, not just prostate cancer, to try to look for specific mutations that might lend themselves to treatment from other that have been studied in other disease types, for example, or for which there is a drug that targets that gene mutation.
So the best treatment for any is prevented to recur. Dr. Cheng, what can you tell us about the molecular imaging to pick up the currents?
Yeah, I think actually I'm going to see if Dr. Dahut wants to comment on that first, because I think he has, they have some pretty exciting trials at the NCI, so I'll let him start.
Sounds great.
Thank you. So prostate cancer traditionally has been a very difficult disease to assess response. And I'm really talking primarily about men who cancer has spread, often progressed after hormonal therapy. So metastatic prostate cancer, castration-resistant prostate cancer. Prostate cancer traditionally has gone to the bone, and the bone is imaged by something which we call a bone scan. And a bone scan doesn't actually measure the tumor itself, but actually measures uptake of a radioisotope, usually technetium. And changes on a bone scan then don't always reflect changes in the cancer itself. So a bone scan can actually look transiently worse when the cancer is getting better, or the bone scan can actually stay the same when the cancer is, even though the cancer again has gotten significantly better. And so it's been very difficult to really assess the ability of new treatments to have an impact on the patient. And so one thing that we've been studying is using what we call molecular imaging. And that is a more sophisticated way of determining the ability of determining how much cancer one has, and hopefully to come up with a way to measure response, and then perhaps to use the imaging as a way to actually treat the patient. We're using something more recently called the PSMA scan. That stands for prostate specific membrane antigen. Again, even though it has the word prostate in it, it is not totally specific for prostate cancer. But opposed to some earlier versions of this scan, it actually allows one to attach a way to image it on the outside of the prostate cancer cell. So this is a sort of a form often of what we call like a PET scan. And by the injection of this targeting technique, one sees a significantly greater number of the prostate cancer lesions, and then also has the ability to measure the response of the treatment in a much more rapid fashion. So some work we've done in collaboration with folks at Memorial Sloan Kettering and at the University of Wisconsin, we've had the ability to have sort of a very early readout of response in different imaging. This is on sodium fluoride PET imaging. But again, with some of this molecular imaging, how well our treatments are working. And I think this has really the ability to truly revolutionize the way we look at prostate cancer, because it is a much more specific for prostate cancer, and the ability to pick up prostate cancer lesions much earlier in one's course. And this may significantly impact how one determines which treatment one chooses, whether it's when someone has more advanced disease or even at the time of an initial diagnosis. So it's a very exciting field at this time.
Great. Dr. Cheng, do you have any comments?
No, I think we are very excited. I'm very excited. I've actually sent patients who have been very interested in the PSMA technology, and they've actually traveled to get onto those clinical trials. So I think there's a lot of excitement and a lot of potential benefit.
So where can we go, or where can people go who are interested in learning more about prostate cancer research and treatment? Dr. Dahut, do you want to start with some resources?
Yeah, so I think it's always great that people start with their own physicians and to discuss their disease and look at options. But I think it's also it's really critical that folks know there are opportunities throughout the country. And I think it's something that, within the day of obviously the ability to access throughout the country through the internet, going through sites such as trials.cancer.gov or simply calling the 1-800-4-CANCER number will immediately give patients a great wealth of information about clinical trials information throughout the country. And it's incredibly important, the value that we who are involved in prostate cancer research gain from the time and effort that patients do by volunteering for clinical trials, because oftentimes what we think makes sense in patients as far as a treatment, once we've actually tested it in a very rigorous fashion, the treatment may actually work better than we anticipated, but sometimes does not work nearly as well as we had hoped. And so it's impossible to overemphasize the importance of clinical trials and really the gratitude we have to the patients who become involved, because without that, the field would simply be on a treadmill and not be able to make any opportunities going forward. The discoveries that really led to the understanding of the importance of abnormalities, what we call the DNA damage pathway, all came from patients who were involved in clinical trials. Patients who really volunteered to be involved in a trial, who volunteered to have their tumor biopsied and sequenced. In other words, the genomics of the tumor looked at in a very careful way, led us to learn that really what was driving prostate cancer was actually different in many men than we had anticipated, and really would lead one to use a very different group of anti-cancer drugs than what traditionally are being used. So again, using these numbers, the trials, the 1-800-4-CANCER phone number, or the trials.cancer.gov, is really incredibly important. In the intramural program, we have many clinical trials that we would be very happy to discuss with patients or their physicians for really a full breadth of prostate cancer clinical states, from newly diagnosed patients, and again, some of the trials I talked about earlier on, which combine immunotherapy and DNA damaging agents. But again, clinical trials are not limited to our campus. Throughout the country at cancer centers and physicians' offices, there are opportunities for clinical trials, which hopefully will help the patients that are being treated, but really can advance the field.
And Dr. Cheng, what resources would you like to put forward?
Well, I support all of or echo really would wholeheartedly, and I echo what Dr. Dahut said, that none of what we have learned, and I think have really made leaps and bounds in the last few years in our understanding of prostate cancer, and really through the efforts and the generous volunteering of our patients and their willingness to share their their clinical course. Sometimes, and I would like to say some trials are interventional trials where people get treatments that are newer and exciting, and we're trying to learn if they're more effective. But sometimes there are circumstances by which patients can't participate in those types of trials, and there are other types of trials like registry trials, for example, that can also be extremely valuable for the field and for other patients, and hopefully for the next generation. And this is particularly true, I think, in with our new understanding of germline mutations, so inherited cancer risk mutations and their association with prostate cancer. One of the things I see on a daily basis in my clinic is really that patients who have these mutations are getting, perhaps considering different treatments because of their awareness of their mutations that are both inherited and in their cancer. But in the cases of the patients who have the mutations that are inherited, they are very interested in learning more about the cancer, in thinking about their relatives and thinking about their sons and their nephews. And so the more we can learn about the biology of a prostate cancer or any cancer in the context of an inherited risk, may be something that will be useful, or will definitely be useful for the next generation in thinking about how we can improve our treatments and how we can do early detection. And there are also early detection clinical trials available as well. So really encourage anyone who might be watching this to talk to their doctors and be proactive in learning about trial opportunities and other resources that are available. I think cancer.gov is fantastic. The trial.cancer.gov is a good site, and locally, I think most cancer institutions have good resources as well to tap into.
Great. Well, at least on behalf of Men's Health Network, we have all those resources on our website that direct people to where they need to go. You can visit that at menshealthnetwork.org. We also have an online men's health center that has a lot of different disease state information, so patients are able to go in and view the different disease topics. We do a lot in prostate cancer, but handle all of men's health, and that can be found at www.menshealthresourcecenter.com. Men's Health Network also, we go into the communities where people live, work, play, and pray. So we have a lot of resources that are in schools and churches and health clinics. So we're all over the country. So if anybody has any questions about that, in addition to the resources that were already mentioned, please feel free to contact us at Men's Health Network. So we've gotten a couple of questions from Twitter, and the first one here, open to anyone who wants to answer: is there a difference between active surveillance and watchful waiting?
So I'll answer that. So yes, there is. So active surveillance is where a decision is made that immediate treatment is not needed, but that the patient needs to be followed because at some point treatment may be indicated. And so that can be done many ways. Sometimes that's done with biopsies done over a period of time. Sometimes that's used doing an MRI, sometimes with a PSA or a combination of things. Watchful waiting is really for patients whose cancer and probably overall medical condition would be a situation where it's highly unlikely that the side effects of treatment would outweigh the toxicities. So this would be applicable for patients potentially of a shortened life expectancy, either due to age or other comorbidities, or for patients that would potentially never be a candidate for treatment because for other reasons. So I think they really are different.
Dr. Cheng, is there anything you wanted to add to that?
No, I think that Dr. Dahut did a good job of explaining the differences. I do agree with him that they are different. One is much more involved and requires close interaction between the patient and their physician.
Now, the final question from Twitter asks, could germline mutations affect treatment after diagnosis?
Maybe I'll start by answering that one. That is very clearly yes. I think at many stages, currently probably the area where there's the most impact in terms of understanding how a germline mutation may affect a prostate cancer patient's care is in the setting of advanced disease, where we're looking at platinum chemotherapy and PARP inhibitors and combinations. And so those two classes of treatment are felt to be exceptionally effective, or hypothesized to be, or we think are going to be much more effective. The early data suggests that they are. And so I think that that is a clear indication for an additional treatment arm in addition to the current armamentarium or current toolbox of treatments that may be especially effective for those patients. So being aware of that, or finding out about whether or not you have a patient has a germline mutation, which would involve talking to their physician, considering going to a genetic counselor and getting that testing done, which is often either a blood test or a saliva test, spit test, to try to learn about whether or not they have an inherited cancer risk mutation that might inform their treatment. The other part of that, of course, is people who have the mutations only in their cancer, which is another portion of that population that might benefit from those DNA repair targeted treatments. So I think the other part of it is that as we grow in awareness, we are looking at those same treatment strategies earlier in the disease course. So there are now efforts and interest in looking at whether we can intervene at the time of diagnosis. Maybe knowing about those mutations might lead us to be more inclined to do, less inclined to do active surveillance, or more inclined to take a different approach. Or, for example, there are trials of looking at treatment right before surgery, or combination treatments with the multiple strategies to try to improve the odds or improve the likelihood of cure. So these are all things that will continue to be important, are currently very exciting, but will continue to be developed as we move forward.
Dr. Dahut, any comments around that?
No, I think that was a great summary of the current state. I think as we learn more about the treatment of patients that have germline mutations, we may be able to give a bit more definitive advice, either at diagnosis or perhaps, when in their treatment course, one should begin drugs that, target the specific pathway, which is their germline mutation impact. So we're not there yet, but I think it's really important information, particularly with men with more advanced disease.
Well, that's all the time we have today. So thank you for spending the time with us, Drs. Dahut and Cheng. Before we sign off, I'd like to remind viewers to click on the letter I that is in the upper right-hand corner of the screen to view the National Cancer Institute videos that contain supplementary information about both clinical trials and how to contact NCI's Cancer Information Service. We hope you enjoyed this YouTube Live. Shortly, this entire video will be available on the NCI YouTube channel. Thank you and goodbye.